I'm very happy to be here again for the MSK case presentation series after this short break in July. On behalf of the Radiology Society of Rio de Janeiro and OCAD, I want to welcome and thank everyone for tuning in today. My name is Aline Serfati, and I'm here with my colleague, Dr. Berang Ameni, who will moderate this session with me, as well as our guest speakers, Dr. Júlio Brandão, Dr. Heba Al-Mutairi, Dr. Beth Petil, and Dr. Sabrina Veras. The presentations today will be recorded and available on demand on the OCAD website, which is ocadmsk.com, and on the YouTube channel of the Radiology Society of Rio de Janeiro. For those of you who are unfamiliar with OCAD, it is a knowledge sharing forum where members post challenging cases on a daily basis and count on each other to solve these difficult cases. To have access to this MSK content, please consider registering on the OCAD website. The speakers today will present their cases, and at the end, we will have a Q&A session. If you have questions at any time during their presentations, please put them in the chat box, and at the end, the speakers will respond to them. Just a reminder, attendees have not been given the permission to screen record any of these presentations, as they may contain material under copyright. Unauthorized recording, use, distribution, and sale of this material without permission from the speaker is illegal. We thank you for your understanding, and without further ado, I will kick off the session. Berang, could you please introduce our first speaker today?
It is my pleasure today to introduce Dr. Beth Petil. She is an ABR certified MSK radiologist. She did her residency training at University of South Alabama and her fellowship with us at MD Anderson Cancer Center in musculoskeletal imaging. She is currently working in rural Virginia, having served as chair of radiology at Central Southside Community Hospital. Her research interests include musculoskeletal cancer imaging and radiology education, and I'm happy to introduce her. Beth, it's all you.
Thank you for introducing me. Okay, so my name is Beth Petil. I have a case of a 66-year-old lady who comes in with right hip pain. So her initial x-rays show that she has bilateral hip arthroplasties. We get an MR after 1 month, and these are some axial STIR images. You can see how there is a lesion surrounding her right hip, which is hyperintense on STIR imaging. And there are some low-level debris within the lesion. These are some T1 coronal images taken at the same time. You can see that the lesion is hypo-intense on T1. These are post-contrast images taken at the same time. You can see how there is no internal enhancement within the lesion. This lesion was aspirated under ultrasound. We can see how the lesion itself is hypoechoic on the ultrasound, and there is no color Doppler flow. The pathology results showed no malignant cells, just abundant mixed inflammation. So these, a lot of terminology is thrown around trying to describe these kind of reactions. You have adverse local tissue reaction, you have ALVAL, which is aseptic lymphocyte-dominated vasculitis associated lesion. You have pseudotumor, metallosis, traniosis, synovitis, polyethylene associated synovitis. So a lot of terms are thrown around. And let's look at the basic components of a hip implant. You have the femoral component, and then you have the acetabular component. The acetabular component has the shell and a liner, and the femoral component has a head, a trunnion, which is the connecting portion, and then the stem, which itself is the part that goes into the femur. There are 5 kinds of FDA-approved hip implants. You have the Metalon metal, the Metalon polyethylene, the ceramic on polyethylene, the ceramic on metal, and then you have ceramic on ceramic. So the adverse effects from these implants can be classified into two kinds based on etiology. You have adverse effects that are resulting from metal ions. This can be systemic or local. The systemic effects can result in neurotoxicity, in thyroid toxicity, or cardiac toxicity. The local effects from metal can involve ALVAL, which is the aseptic lymphocyte-dominated vasculitis-associated lesion. You can also have metallosis or particle disease. And the polyethylene associated adverse effect is usually local. This can result in particle disease or polyethylene associated synovitis. So let's look at the differences between these four kinds of entities. So you have the ALVAL, which is caused by the metal ion. It usually results in synovial thickening, which we can see on imaging, and it may also result in capsular dehiscence, again, which can be seen on imaging. This kind of hypersensitivity is type 4 mediated, which is lymphocyte mediated. Then you can have metallosis, which is caused by larger metallic debris. The metal itself would be visible on the MRI, showing the low signal. And you can also have low signal osteolysis. This is usually mediated by a histiocytic reaction. Then you have the particle disease, which can be caused by metal ions, polyethylene particles, or even the cement that is used. This can result in osteolysis or cystic changes in the bone. And this is mediated by a giant cell reaction. The fourth kind is the polyethylene associated synovitis, which is caused by polyethylene. This is also caused by a giant cell reaction, and the main imaging finding is this frond-like hypertrophied synovium. This is an example of an ALVAL, which is caused by the metal ion. It has a lockulated abscess-like appearance, and it also may result in synovial thickening and capsular dehiscence. On H&E preparation on PATH, you can see how there is a blood vessel and all these lymphocytes are clustered around the blood vessel. So it's a lymphocyte-mediated vasculitis associated lesion. Now we have metallosis. You can see the low signal areas on the MRI, which are from the actual piece of metal being in there, tiny particles of metal being in there. On the H&A preparation, you can see the metallic debris which have been phagocytosed by the histiocytes. Now we have particle disease, which can be caused by polyethylene, metal ions, or even cement. This shows the lytic appearance of the bone. And on H&E's preparation, you can see how there is a giant cell. Giant cells are huge cells with multiple nuclei in a single cell. And these are phagocytosing the metal particles. And here you have metallic particles within the connective tissue. The fourth kind is the polyethylene associated synovitis. This is an MR image, which shows the frond-like, fragile looking hypertrophied synovium. And on the H&A preparation, you can see how there are, again, giant cells, but here they are phagocytosing the PE flakes, the polyethylene flakes. Other confusing terms that I have come across are adverse local tissue reaction, which is kind of an umbrella term to describe any kind of local tissue reaction. Then you have the pseudotumor, which is any local tissue reaction, which also has a mass effect, like ALTR or metallosis or ALVAL. Another term that I have come across is trunnionisis, which is just wear of the trunnion, or the part which connects the femoral head portion of the arthroplasty to the femoral stem portion. The treatment options in these cases usually involve either monitoring, which you can monitor by using MRI, or monitor the iron levels. The definite treatment is usually revision of the implant. These are my references. Thank you.
Thank you very much, Beth. Love the images, love the pathologic correlations. Beautiful, thank you.
Thank you, thank you.
Okay. Now it's my pleasure to introduce my friend and the great radiologist from Rio de Janeiro, Dr. Sabrina Veras. She graduated from the Federal University of Piauí with a medical residency in radiology and a fellowship in musculoskeletal imaging at Santa Casa de São Paulo, and a second fellowship in MSK image at the Regis Salenco Hospital in Lille, France. She's a practicing radiologist at the IRM and Felipe Matoso Labs, acting as one of the fellows professors. Dr. Sabrina Veras is co-author of book chapters and MSK radiology papers. Since 2019, she has been one of the active participants of the MSK Image Group of Rio de Janeiro. And since 2013, she has coordinated the monthly MSK imaging meeting of the Rio de Janeiro's Orthopedic Society. And with that, please, Sabrina, share your screen.
Okay, just a minute. Hello, everyone. It's a pleasure to be here. I'd like to thank the organizing committee, especially Dr. Aline Sefari. So let's talk about my case. My clinical case is about a 79-year-old female. She was involved in a car accident 1 week prior to the doctor appointment. Since then, she has been reporting upper back pain. On physical examination, the neurologist found signs of spinal cord syndrome with urinary and fecal incontinence, marked spastic paraparesis with progressive worsening, and sensory level below T5 sensory dermatome. So she came to our clinic to undergo an MRI, and these are the findings. Here we have the sagittal images, and we can see extensive mass occupying the epidural space from T5 until T11, displacing the spinal cord. We can see that the lesion presents ISO signal on T1 weighted images, slightly hypersignal on T2, and hypersignal on STIR weighted images. We can notice also a small fracture in the inferior end plates of the T12 vertebra with adjacent bone marrow edema here. Here we have sagittal T1 with fat saturation before and after the gadolinium. And we can note that the lesion presents a diffuse and homogeneous enhancement to gadolinium. And we can conclude that it's not a post-traumatic hematoma, but a mass. Here we can see more magnified images, and we can note that the lesion extends posteriorly, involving the posterior elements of T8 vertebra, with hyposignal on T1 weighted images, hypersignal on STIR, more evident, and also a prominent and diffuse enhancement to gadolinium. We can notice also enhancement of adjacent soft tissues here in this level. Here we have sagittal and axial T2 weighted images. Please note how the lesion displaces and compresses the spinal cord here, here, and especially in this level. And we can notice also that spinal cord presents hypersignal on T2 weighted images. That means a compressive myelopathy. Please note how the lesion extends posteriorly at the T8 vertebral level and compromise the posterior elements here and here, and also the paraspinal muscles and adjacent soft tissues here. We can compare this level, abnormal, with this level just below the lesion with a normal aspect here. Here we have sagittal and axial T1 with fat saturation after the gadolinium. And we can note the diffuse and homogeneous enhancement of the epidural lesion here and here. And we can also notice also the enhancement of the posterior elements of the T8 vertebra, with also enhancement of the paraspinal muscles and adjacent soft tissues. So she was transferred to the hospital and was submitted to a surgery to decompress the spinal cord. And the histopathologic examination was compatible with plasmacytoma, infiltrating bone, fibroadipose, and muscle tissues. The pathology suggested us to correlate with clinical and radiological finds to consider multiple myeloma. So after the surgery, she underwent a PET-CT, and these images were kindly considered by Dr. Dominic. On PET-CT, we can note post-surgical alterations with laminectomy from T5 until T11, the same level of the epidural lesion that we have seen at MRI. We can see again the small fracture on the inferior plate of the T12 vertebra, as we have seen at MRI. And we can note an increase in FDG metabolism of the bone marrow, more evident in thoracolumbar spine and the pelvis, here and here, but without corresponding morphological changes. So she didn't have osteolytic lesions, and this PET-CT was not specific to conclude as multiple myeloma. And it was suggested to correlate with laboratorial findings. After that, we have the laboratory examinations results. She had no other features for CRAB. She had no hypercalcemia, no renal impairment, no anemia, and no more bone lesions. She had Bence-Jones proteins in urine. Her kappa lambda ratio was 300, and the bone marrow biopsy showed plasmacytosis 15%. With these findings, we can conclude as multiple myeloma with extramedullary presentation. So let's talk about multiple myeloma. It is a clonal plasma cell proliferative disorder characterized by primary infiltration of bone marrow and excessive production of abnormal immunoglobulin. It is the second most common hematologic malignancy after the lymphoma, and it is the most common primary bone malignancy, and occurs between 40 to 80 years old. It represents 1% of all cancers and is likely more than 10% of hematologic malignancies in the United States. Bone disease is one of the most prominent features of multiple myeloma, and imaging has an important role in diagnosis and follow-up. Here we have one table showing the diagnostic criteria for multiple myeloma, defined by the International Myeloma Working Group. Please note in red the features that we could see in our patient. She had clonal bone marrow plasma cell more than 10%. It was 15%. She had biopsy proving extramedullary plasmacytoma, and she had involved and uninvolved, serum-free like 10, ratio more than 100. She had 300. Let's talk about extramedullary myeloma. There are several controversies surrounding the precise definition of extramedullary myeloma. It is an unusual presentation of multiple myeloma. A little is known about its incidence and natural history. It is seen in 7 to 18% of newly diagnosed myeloma and 6 to 20% during the disease course. Extramedullary myeloma may be found at the time of multiple myeloma diagnosis, called primary EM, or at the time of myeloma relapse, called secondary EM. It has poor prognosis due to decreased overall survival. Extramedullary myeloma can also be divided into two more groups. The first one is called soft tissue-related disease, resulting from plasma cell infiltration into soft tissues with no relationship to the bone, like we can see in these black arrowheads here and here. And it can also be called bone-related disease, extending directly from osteolytic bone lesions, also known as paramedullary myeloma, like we can see in these blue arrows here, and especially here, the same we have seen in our case. There are no established guidelines for the imaging workup for patients with suspected extramedullary myeloma. MRI is a highly sensitive method for EM diagnosis, especially for its high resolution of soft tissues and CNS structures. PET-CT permits not only an anatomical, but also functional imaging, enabling assessment of focal activity of EM. Moreover, it's frequently necessary to perform biopsy, and it's necessary to distinguish between EM tumors and secondary primary tumors that may occur in multiple myeloma patients. Here we have one table showing the distribution of extramedullary myeloma. When we talk about lesion contiguous with the bone, the most common presentation is as epidural and perispinal mass, similar to our case. And the most common location was at thoracic spine. Here we have one example from this article, and we see extramedullary myeloma presenting as a epidural mass, similar to the case I'm presenting here. Here is another example from another article, very similar to the case I'm presenting also. When we talk about differential diagnosis of epidural lesions, we have to think about all these lesions: lymphoma, metastasis, epidural abscess, amyloidoma, meningioma, neurinoma, vascular mass, hematoma, and angiolipoma. Here we can see one example of epidural lymphoma, very similar to our case. Here, another example, an epidural metastasis from gastric cancer. And here, an epidural hematoma. So, as key points about extramedullary myeloma, it is an unusual entity that has non-specific image features at MRI and should be included in the differential diagnosis of epidural mass lesions. Knowledge of its image features may help radiologists to suspect it. Contiguous extramedullary myeloma most commonly occurs as a mass in the perispinal and epidural locations, like the case I'm presenting. And the overall prognosis in terms of survival is poor, but early decompression can prevent neurological deterioration and improve quality of life. I'd like to thank my dear colleagues Eduardo Brown, Jeanne Shu, and Patricia Martins that helped me a lot with this presentation. Thank you very much.
Thank you very much. Beautiful case, and also very, very good explanation on the differential diagnosis of it. And I especially like this last photo you put in your presentation. Beautiful place. I want to tell everyone that this is in Brazil.
Yeah.
Beautiful country. Okay.
Yeah. Thank you.
Okay, moving on to the next talk. It's my pleasure to introduce Heba El-Mouteiri. She is currently working as an assistant professor of radiology at King Abdulaziz University Hospital in Jeddah, Saudi Arabia. It's also where she went to school. She did her residency training at Lahey Medical Center in Boston and her MSK Radiology Fellowship here at MD Anderson Cancer Center. She also practiced for a couple of years at Western Virginia University as an assistant professor of radiology. She currently practices as an MSK radiologist with a focus on bone and soft tissue tumors. Since joining King Abdulaziz Hospital, she's been working on expanding the sarcoma multidisciplinary conferences and developing an MSK radiology fellowship program. Heba, it's great to see you remotely. The screen is yours.
Well, thank you, Dr. Amini and Dr. Sarfati, for your invitation and kind introduction. Let me share my screen. All right. We'll start with our first case of a 50-year-old female with a left shoulder pain. And we see a frontal shoulder radiograph where there's complete destruction of the humeral head, the scapula, the glenoid, and the coracoid process. We see a soft tissue haziness centered at the joint. We also see multiple bony debris and fragments. And we note the sharp edges at the proximal humerus for this lesion. And we have a CT scan. We see multiple well-corticated bony fragments. We see the sharp edges at the glenoid and scapula. We see the soft tissue haziness with multiple debris in it. And we see sharp edges at the proximal humerus. T1 weighted images, similar changes of soft or of a hypointense signal central in the joint and multiple osseous fragments. We don't see any other abnormal bone marrow signal. We don't see any additional findings here, and we see the well-corticated or the sharp edges. Post-contrast images, T1 fat sac with a peripheral enhancement, but no central enhancement, no soft tissue, and no bony enhancement. So what's the most likely diagnosis? A lot of residents are asking for this format of multiple choice questions. So that's what I've been doing lately. So we think of chondrosarcoma. What goes against it is the mass is not centered within the joint as we see here. This doesn't appear so aggressive because of the sharp and narrow zone of transition, some metastasis, septic joint. And then we think it's what do we think it is? And what would you do next? Would you check the hemoglobin, MRI spine, chest radiograph for metastasis? Would you tap the shoulder? And in this case, it's a neuropathic osteoarthropathy of the shoulder. And classically, you have the 5 Ds where we look at the bone density, which is normal unless there's an underlying condition. We have distension of the joint and bony debris, cartilage destruction, joint disorganization, whether dislocation or deformity. And the location is strongly suggestive of etiology. So you can have a neuropathic arthropathy depending on the location will have a different etiology. And what we are used to seeing is the ankle and midfoot where we have diabetes. Those are most frequently encountered. If you have a syrinx, you can have a shoulder arthropathy. If you have a myomeningeal seal, it would be in the lower extremities, knee. And about 20% of patients who have syringemelia have developed Charcot's joints. You can have alcohol, which is less common. It can involve the hip and steroid injections in the knee, syphilis, and congenital insensitivity to pain. Morphology, you can have a more hypertrophic bone, which is about 20% of the cases. Atrophic is about 40% of the cases we see in diabetic patients in the ankle and foot, or combined both types, about 40% of the cases as well. So what would you do next in this patient? You probably want to, so I think it's reasonable to do a TAP. MRI cervical spine is what was done next, and this is the sagittal T2 images of cervical spine, and we see the T2 hyperintense syrinx in the middle of the cervical spinal cord. So the teaching point is to differentiate this from chondrosarcoma. How would you differentiate the two? And we see here X-ray frontal and lateral radiograph with scapula, and we see what is a soft tissue mass with a rings and arcs of the chondroid matrix. We have also a CT scan of this case. So this mass arising from the scapula with a large soft tissue components and rings and arcs of the matrix, which is classic chondrosarcoma. Another companion case is what we see every day with our 54-year-old female who experienced left foot pain and swelling suddenly over the weekend. And we see distension of the joint, multiple osseous fragments, and disorganization of the joints, lucency, and increased density. This is a T1 weighted image. It would be difficult to exclude and superimpose osteomyelitis with this dark T1 signal. And then the post-contrast images would be helpful. Now the distension and the bony debris can distend beyond the joint, as we can see here, is going upward. And the second case I have is a 13-year-old male who presented to the emergency department after a sport injury and was complaining of pain. And there's no fracture, nothing acute, but we see this lucent tubular-shaped lesion in the mid-diaphysis of the radius, and a little bit of intramedullary cortical involvement. And this is magnified image of it, and a frontal radiograph, stipulated appearance and lucencies. So the patient did get a follow-up MRI. This is the post-contrast images. We see a bit of enhancement, and then the T1 is intermediate signal with dots of hyperintense signal, similar things we see on T2 with dotted hyperintense signal and a fat signal within this lesion. So differential diagnosis for it was, is this a hemangioma? Could it be EG, epithelioid hemangioma? Those that usually present with pain. This patient was asymptomatic in terms of localized pain. And due to the small size and benign features, they decided to follow up on this patient. But we thought it was more in line with hemangioma. And hemangiomas are about 1% of all bone tumors. They're more dominant in female, seen in the spine and the skull that you see frequently. But hemangioma in the long tubular bones are rare. Then there's a little bit of literature review that I did just to see if there's any radiological guide to help us. The top two articles are more recent, the last couple of years, and they have a small number of patients, about less than 10 each. And then the one at the bottom is a little bit older, but they went through and reviewed about 75 cases and 5 cases of their own, and to see what findings they can find. And the takeaway from it is that most common is medullary hemangioma is the most common location, about 50% of the cases, and then periosteal and intercortical are less common. They are rare. We don't see them often. Their radiological appearance varies a lot, and that could be challenging task for us as radiologists. The last, those 2 studies, none of them made the diagnosis pre-operatively. And then the typical radiological classic presentation include coarse trabecular bone pattern or soap bubble appearance. And the treatment for those were curettage or excisional biopsies, and they didn't report any recurrence on them. And for treatment, they say if a small benign lesion that can be diagnosed and followed up closely with the imaging. For a larger, more expansile, complex lesion, you need further imaging, and you would need to biopsy those and further and follow them closely. Most of the cases were also presented with pain. Our case did not have any pain, so that was a bit different. That's our second case. Our third case is more straightforward, 35-year-old male with hip pain. And we see a lucent lesion in the femoral head. Some of the margins are sclerotic, some a little bit defined, but you can see sclerotic rim around them. And this is the lesion over here. The patient did present with pain, so a lucent epiphyseal lesion, and someone who's 35. Things you want to think about is one of them is clear cell chondrosarcoma, which this was excised and proven to be a clear cell chondrosarcoma. And they are a subtype of chondrosarcoma, about 2% of all chondrosarcomas. They're typically low grade, and they get their name from presence of clear chondrocytes, which contain abundance of voculated cytoplasm due to the presence of glycogen in them. And typically 3rd to 4th decade, male more than female, and about 20% of the cases would have calcification, and then they're predominantly lytic and expansile. But I think the location is always key, and that it's located in the epiphysis of the bone. Those are the cases I have for today.
Thank you, Heba. Very nice cases.
Thank you, Heba. It's my pleasure to introduce Júlio Brandão. Júlio is an assistant professor of radiology at the Federal University of São Paulo, Brazil. He completed his postdoctoral fellowship in musculoskeletal and quantitative imaging in the Department of Radiology and Biomedical Imaging at the University of California, San Francisco, where he currently is an associate researcher. He's an active member of the Radiology Society of North America and the International Skeletal Society. He has authored and co-authored over 30 peer-reviewed articles, and his specific areas of research interest include hereditary and inflammatory myopathies and pediatric musculoskeletal oncology. Please, Julio, take it away.
Hello, everyone. Thank you very much for the invitation. It's a pleasure to be here. Thank you very much for the kind presentation. So I'm gonna share so this is a case that we have a few months ago. It's about a 30-year-old female presenting with lower back pain, fever, night sweats, and weight loss in the last 2 months. She did not present any previous medical history. And in the medical examination, she presented with mild pain on palpation of spinous process and lumbar paravertebral musculature. And in the laboratory test, she had C-reactive protein elevated. This was the main laboratory abnormality. Here we identified the first X-ray, where we could not identify any significant bony abnormalities or soft tissue abnormalities. We just identified this scoliosis to the left side. She progressed the radiological studies with a CT. Here we have the bony CT and soft tissue, where we could not identify any significant bony lesions in the lumbar spine, and either a significant soft tissue abnormality as well. When we look to the iliac region, we identified this small lesion in the right iliac that have this thin sclerotic halo, but we could not identify any cortical disruption or a soft tissue mass. She proceeded the investigation with a CT, and in the CT spine MRI, we identified this diffuse bony abnormality at L4, presented with diffuse low signal on T1, a high signal on T2. This specific geographic peripheral enhancement in post-contrast imaging. When we look to the axial imaging here in T2 and post-gadolinium, we identify that have a small amount of soft tissue mass inside the spinal canal. And here we can identify as well the previous lesion that we identified on CT on the right iliac bone, presented with low signal on T1, this periphery and geographic line in T2, and periphery enhancement in the post-contrast imaging. Because of the low signal on T1 and that small amount of soft tissue inside the spinal canal, we decided to biopsy the L4 vertebral body. And the results of the biopsy come with bone marrow necrosis. We tried to relate this bone marrow necrosis to any previous pathology of this patient. We could not identify any significant association in her medical results. And we hypothesized that this could be related to any atypical infection, like in some types of tuberculosis, or this could be related to any neoplasm. And we proceed the investigation with a thoracic and abdominal CT studies. And the most important finding was the diffuse hypovascular masses in the both kidneys. These lesions were biopsy, and the results come as a diffuse large B cell lymphoma. After the diagnosis, the patient started the chemotherapy and the planning to do the bone marrow transplantation, but the disease was extremely aggressive. She progressed extremely fast, even during the treatment. And here showing 2 months after the prior MRI, these diffuse bony and soft tissue lesions. And we start to see a lot of this necrotic pattern lesions all over the body. When we look to the spine of these patients, we see diffuse imaging, pretty similar from the ones that we previously identified just in L4. So with this necrotic, diffusely pattern in almost all vertebral bodies. The purpose of this presentation was to discuss a little bit about bone marrow necrosis, because this is a clinical pathological entity that is completely distinct from avascular necrosis and osteonecrosis. It is important to understand that bone marrow necrosis tend to be more extensive and usually compromise the vertebral body, different from avascular necrosis that tend to be more focal and periarticular and rarely on the vertebral body. The bone marrow necrosis is related to necrosis of the myeloid tissue, different from avascular necrosis that's really related to involvement of the trabecular bone. We know that bone marrow necrosis do not tend to progress to vertebral body collapse, different from avascular necrosis. And the most important point is that finding of bone marrow necrosis could be associated with malignancy. So bone marrow necrosis could be associated with malignancy, usually hematologic. It's important to highlight that this can occur before of the diagnosis of malignancies or at recurrence. Because of bone marrow necrosis can occur before the diagnosis of malignancy, an extensive search for malignant disease is justified whenever a bone marrow necrosis diagnosis is identified in isolation. Also, we find some case report associating bone marrow necrosis with some cases of sickle cell disease and infection, but always when we identify this finding, we have to exclude malignancy, especially hematologic disease. The imaging of bone marrow necrosis presents as a central area of variable signal intensity surrounded by a distinct peripheral enhancement rim. Remember that this bone marrow necrosis tend to be diffuse, extensive, really distributed in the vertebral bodies and the pelvic bones. And we have that geographic after contrast enhancement. Here is just showing another case. This is a 66-year-old man with no previous disease, presented with diffuse spine pain. When we do the MRI, the findings are quite similar, but much more diffuse from our previous case. We identified this signal abnormality with low signal on T1. We identify this geographic hyper intensity on T2 and this peripheral ring of enhancement on post-contrast imaging. The biopsy showed bone marrow necrosis. And after 1 month, this patient received the diagnosis of a lymphoblastic leukemia. Here, just showing some images from the literature, showing this specific pattern on T2 that present with this geographic with hyper intensity lines here, pretty similar from our cases. So the take-home message, remember that bone marrow necrosis can present as a geographical appearance surrounded by a distinct peripheral enhancement rim, tend to be more extensive and usually diffuse involve the pelvic and the spinal bone, especially the vertebral bodies. Remember the association with malignancy, especially hematologic disease, and this could occur before or at recurrency of the disease. And an extensive search for malignancy disease is justified whenever bone marrow necrosis is diagnosed in isolation. Thank you very much.
Thank you very much, Julio. There's a question from Eduardo Brown to Dr. Reba. Do you use perfusion MRI to try to differentiate chondroma from chondrosarcoma?
I'll be honest, it's easy to say we're going to do more imaging, but the truth is it takes a long time, and a lot of our ortho-onc don't want to do more complex series. So we haven't used that. And I had one ortho-onc who'd only do T1 and stir images. He wouldn't even give contrast. Yeah, we can do that. It might help. But in other cases, if there's pain, if we do a short-term follow-up and there's increase in size, then we raise a concern for clear cell carcinoma. That's what we do. But theoretically, it might help, yes.
Okay, any more questions from the audience? Devang, do you have any questions?
Yeah, I had a question for Dr. Veros. That was a beautiful myeloma case. Do you guys do whole body MRI or do any diffusion on your spine MRIs? The reason I ask is on the conventional imaging, when you see an appearance like that, we're always confused between extramedullary hematopoiesis, versus malignancy. And I find that diffusion can help in those cases.
I was waiting for this question.
I'm glad I could help.
Yeah, that was one limitation. Can you hear me?
Yes, we can hear.
At first, we didn't do because it's not so recently. But there is a discussion if it would help because for the International Society of Myeloma, they suggested with this presentation, extramedullary is much better to undergo a PET-CT because it's better to see extramedullary disease than MRI. The MRI can lose them. And I don't know if it would free the patient from biopsy. Probably they
I think she's frozen. You're muted, Devang.
Okay, yeah. I thought it was just me that wasn't hearing. Okay.
Don't know, maybe something with her connection. Devang, in your practice, do you use perfusion MRI to differentiate enchondroma from chondrosarcoma?
There's papers that have been published saying that you can differentiate them. Our biggest challenge is, differentiating enchondroma from low-grade chondrosarcoma, and for those, unfortunately, the imaging doesn't help that much. So while we are starting to do perfusion, and we've run into the same issue as Heba with the surgeons not enjoying the extra sequences, it's in one more piece of information that we can use, but we haven't had much experience with it.
Okay, thank you. I think she's back.
Hi, you're muted, Dr. Veros.
I can hear you, Sabrina.
Oh, sorry.
Okay, now I can hear you.
I was using the internet from the hospital and failed, so I'm using my cell phone. Okay. I don't know what part did you hear. We didn't do, and I don't know if the multiparametric images would change what happened, because it would be necessary to do the biopsy anyway, and she had to decompress the spinal cord anyway.
That's
so
true.
I don't know if it would help a lot. And it's interesting, this case, because if you see in PET-CT, there were no hypermetabolism at the epidural space after the surgery. We think that he took all the epidural lesion with the surgery,
Wow.
I don't know about that. Sorry.
No, that's perfect. Thank you.
Okay, I don't see any more questions here. I want to thank you again for tuning in today, and I'm looking forward to the next session next month. Thank you. Thank you all. Bye-bye.